Assalamu alaikum and a very good evening to everyone. I am Dr. Adan Zahoor, COO, Experience Dentistry. It's my absolute pleasure to welcome everyone to the post summit webinar on oral and maxillofacial fractures. We are honored to have Dr. Muhammad Ehsan Ul Haq, a renowned oral and maxillofacial surgeon, assistant professor, and consultant at King Edward Medical University and Mao Hospital, Lahore. As our guest speaker, leveraging this vast clinical experience and academic achievements, Dr. Hassan will be guiding us today on the topic radiographic clues to maxillofacial fractures in general practice. We are privileged to have him with us and look forward to an enlightening session. Let's begin the session. Dr. Hassan, the stage is yours.
Bismillah Rahman Rahim. Thank you very much for the organizers for this organizing this lecture, and I'm really grateful to present over here. And this is very useful topic, the radiographic clues of maxillofacial trauma for general practitioners. So thank you again, once again, for introducing me. So, in the today's lecture, in this conversation, I would like to tell you about all those basic clinical signs and symptoms along with the radiographic findings. So, mostly I will focus on the radiographic signs and symptoms. Once the patient presents to the general practitioner or to the person who is not qualified maxillofacial surgeon, what signs he can observe, and he can refer the patient to the maxillofacial surgeons immediately. So my presentation would include the different kind of radiographs mostly, and I will tell that GPs often encounter trauma before the specialist, as I told you, and the goal will be that they should detect the early signs, and so that they can refer the patient timely to the maxillofacial surgeons. So the basic radiographic views. First of all, just remember these basic radiographic views are uh, uh, the periapical view. All my colleagues knows that for the dentoalveolar injuries, once we think clinically that there is a fracture to the tooth or the tooth is mobile, we do have mostly the periapical radiographs, and often we do have the occlusal x-rays. And the most common x-ray, which you know that is the OPG, which is called orthopentomogram. This is very important X-ray. It tells us about mostly the mandibular continuity and the injuries, fractures to the mandible, and to some extent to the maxillary dentoalveolar area as well. So the next X-ray we do have for the mandibular fractures are PA mandible, Waters view, which is also called paranasal sinus view. This is we use to check for the mid-face fractures and to see the sinuses. And then the gold standard is CT scan. As you know, it is three-dimensional X-ray. So just remember all these X-rays for the GPs. They should know that OPG is must. If you suspect the mandibular fracture, then we must have PA mandible, as I told you, for symphysis, body and angle fractures. I'll tell you in the further in the next slides. So quickly going through this, you know that our skull and the facial bones include the zygomatic bones, frontal bone, nasal bone, maxillary bone, and the mandibular bone. So here you might have seen this frequently on your books. So remember these lines. Once you see the paranasal sinus X-ray, just remember my this advice that you should have paranasal sinus X-ray for if you are suspecting mid-phase fractures. So you have to draw imaginary lines like this. The first line, which is along the periorbital rims, the second line, which is along the nasal bridge, and then periorbital rims going through laterally to the zygomatic arches, and the third line to the upper alveolus area. If you will draw these imaginary lines in your mind, you will be able to see the fracture of the superioorbital rims, the frontozygomatic suture area, and you can see the orbital, you can compare the orbital volumes, that both of the orbits are equal or not. And of course, all these signs and lines to be compared with the clinical signs and symptoms. Then you see the fluid level in the frontal sinus. The second line, as I mentioned here, is the fracture for the zygomatic arches, and the fracture through the inferior orbital rim, as I told you, and soft tissue window, the maxillary anterior wall. Fracture can be seen if you draw these imaginary lines in your mind. And just look at the line 3. I should go back, and you see the zygomatico-maxillary buttresses, and this shows the fracture of the zygomatic bone or fracture of the maxilla. So also you can see the fluid level in the maxillary antrum. So, there are some direct and indirect signs. So, dear colleagues, just remember this thing, that you should know all these very basic signs to the patients who present to you with the history of trauma. Number one, the direct signs. Few are direct signs and the few are indirect signs. The direct signs are the separation sign. On These are all on the radiographs, and the separation signs means you see the suture, and if it is separated, you can see the gap in that. It means that it is a suspicious area. And if the some continuity is overlapped, the bones are overlapped to each other, it is again a direct sign. And then if you see any suture area like frontozygomatic suture area, you see there is a gap over there, it is again, and in always compared with the intact side. And if there is a gap, it means they can be fractured. Then there can be bony steps, like they are not in continuity, they are like in this, there is a step formation. And then in the mandibular area, mostly periodontal ligamental whitenings and abnormal linear density you can see. And sometimes you see the disappearing fragment sign and abnormal angulations and displaced bones. So all these are direct signs of the fracture. So these easily you can see on the above mentioned radiographs, as I told you. Then there are some indirect signs. Indirect signs are, of course, they will be swelling to the soft tissue. There will be sinus opacification. If you compare the sinus with the intact side, which is non-traumatic side, there will be radiolucency in the intact side, and there will be radio opacity in the injured side. So this radio opacity means either there is a blood or there is a fluid inside too. So if it is more radio opaque, it is a sign of the blood inside. Or then you can see the occlusal planes. Of course, such patients who got trauma to the jaws have their occlusion is deranged. So it's a very clear cut sign that they can be fracture over there, along with if there is a step deformity. So there can be dental injuries, you can easily see. So the most common fracture bone on the fascia region is the mandibular fracture. The mandible is the lower jaw, and the signs are on the radiographs. For the mandible, as I told you, that the OPG orthopentomogram is the ideal X-ray for to see the mandibular fractures, and never ever see the fracture on one X-ray. Remember this. Always you should have two views for to evaluate the displacement and the confirmation of the fracture. Like if you are going to have OPG, also ask for PA mandible. This is also called PA face. Few people are called it as a PA face. So always have these two X-rays always. So the radiolucent line, fracture line can be seen, cortical step deformity, loss of mandibular continuity. These are all signs which already I told you that that can be seen on the radiographs. So here I think this picture is not clear. Sorry, but you can see uh, if you can see my cursor that there is a radiolucent line on the body of the mandible on right side. uh, in further x-rays here you can see on the x-ray on the left side you can see in the midline there is a separation sign, or you can see there is a gap over here. And in the comparison to the right side of the slide you can see there is no gap after the fixation of this fracture. You can see plate over there under the mandible. So this is just I put to show you the clear difference between the fracture and the fixation. Here you can see separation sign, a step deformity. Uh, if you see the lower border of the mandible, there is a discontinuity. This is also called step deformity, and there is a separation sign, a radiolucent line over there. So easily you can see it's a fracture over there. So here, the condylar intracapsular fracture, the condylar head, it is sometimes very difficult for my colleagues, the GP general practitioners, but always look for the condylar borders. As you can see, the head of the condyle is separated. And mostly edentulous mandibles fracture like this, the bucket handle kind of fracture. It is, you can see the step deformity here and step deformity here on both sides, and this midline piece of the lower bone is displaced. It is downward displaced, and such fractures can be easily diagnosed by the general practitioners. So as I told you that the condylar fractures, if you see, there is a loss of condylar outline. Always compare this with the intact side. And sometimes you have both condyles fracture, but always try to, the basic principle for the radiograph is to always compare the fracture side with the intact side. Sure. So the other sign is if you compare, there is a shortened ramus height. So from the starting from the condylar head to the ramal area at the lower border, if you compare with the intact side, it will be due to the fracture. It will be the less height over there. So there can be overlapping signs, and they can be clinically. If you see, they can be open bite and to the opposite side. So remember this sign as well. Whenever there is a fracture of the condyle on one side, that side will occlude first, and the other side will be, there will be open bite. So this is another sign clinically you can see. So here in this slide, the right side of the condyle, you can see there is a discontinuity at the ramal area. This is called subcondylar fracture. It is out of the fossa. You can see it is rotated anteriorly, medially. You cannot say on this X-ray medially, but it is rotated anteriorly. And on the other side, and the clinical picture, it is fixed. And on the radiograph, you can see now it is in the fossa, and there is no separation sign. So as I told you that always the gold standard is the CT scan. CT scan, as I told you, that it gives the multi-dimensional views. It can give the three-dimensional area. You can see all the bone all over from three-dimensionally. So there must be no doubt of the fracture, and its advanced form is the CD with 3D scan. I will show you. So the orbital floor fractures most of the times in the mid face area we find this, and the orbital floor is very easy to diagnose if you just follow my those the first slide which I told that you have to draw three lines, one from the superior orbital rim, three imaginary lines, the second from the inferior orbital rim, the third from the upper alveolus. So, if you draw these imaginary lines, one thing is that there will be this increased diameter of this orbital area, and the other sign of the orbital floor is that in this maxillary antrum area, there is a teardrop sign, some soft tissue radio dense areas will be coming appearing in this radio lucent maxillary antrum area. So this is also a sign of orbital floor. Sometimes we have in the mid face is the zygomatic complex fracture. Uh, so this is again very common fracture among the road traffic accident patients. So this is called zygomatic complex because it is a complex bone. It has four legs, just like a chair. So most of the times these are four legs get fractured. One leg, I should tell you the name, that it is connected with the frontal bone. The other leg is connected with the this frontal process of that is more forming the inferior orbital rim area. It is connected with the maxilla, and the third process again connecting through the buttress, you can feel intraorally to the maxilla, and the fourth one is to the zygomatic arch area. So it has four legs, two connection with the maxilla, one with the frontal bone, one with the temporal bone. So in this CT scan slide, which is an axial view, you can see the zygomatic bone has depressed inside, it has moved inside, and here in this axial view slice, you can see the infraorbital rim area has been moved inwards. The arrow is showing. And again, in the CT scan, if you see the mandibular CT scan area, you can see the mediolateral displacements as well, which is not seen on the OPG simple X-ray. You can not see the mediolateral displacements. You can only see the superior inferior displacements on the X-ray simple plain X-ray OPG. So again, on the if you suspect any mid-facial fractures, remember this single X-ray, which is called Waters view, or you can ask for to have this PNS view, and always write down that you need to have the PNS in 45 degrees. So that again shows those all signs already I mentioned over there. So also you can see there are very common fractures like maxillary Leaford 1, Leaford 2, Leaford 3. These are the traditional injuries which were happening in the past, but now nowadays when the high impact vehicles are in on the roads, these classical fracture signs are no more over there. So most of the times we have comminuted fractures of the maxilla and not the classical Leaford 1 and Leaford 2. Sometimes we have combination of Leaford 1 on one side and the Leaford 2 on the other side. So these classical injuries and fractures are no more. But just to revise that, the Leaford 1 is called the dentoalveolar fracture. The upper only the maxilla get fractured. There is a separation sign just above the roots of the teeth, the maxillary teeth. This line goes posteriorly to the pterygoid plates, and this fracture, once if this fracture has happened, the maxilla goes back, it drops back, and there is open bite. So remember, in all those maxillary fractures, either it's a Leaford 1, Leaford 2, Leaford 3. In all those fractures, there will be anterior open bite and the posterior we called gag. The posterior teeth gets occlude first, and the anterior teeth remains open, and it's again a clinical sign for the foot fractures. And also, if you see the leaf 2 fracture, clinically you will have periorbital ecchymosis and the swelling and edema on the infraorbital regions. And you can see the blood over here, that is called the ecchymosis. And you can see blood in the eyes on the medial side, which is called subconjunctival hemorrhage. So again, this disjunction causes the posterior gag, and it causes the anterior open bite. So same this leaf 3. What happens that there is a disjunction. This is also called craniofacial disjunction. There will be posterior gag and there will be anterior open bite. So on the radiographs, you will see the separation signs on the frontozygomatic suture areas, and they will be lengthening of the face. So if you see this, as I told you, that the CT scan also have a 3D reconstruction, which is called CT with 3D reconstruction views. It is I always call that this is a layman X-ray. This we anyone can read this X-ray. Here you can see there's a fracture line in the symphysis area. Everyone can see that. You can see the fracture, comminuted fractures in the zygomatic areas, in the frontal bone. All the segment is missing. So this is very easy to read for even a layman person. So this is a facility available everywhere in most of the places. This is very good to diagnose, and we often order for this kind of X-ray if we suspect multiple facial fractures and if we suspect many pieces of the facial bones, and that is called as panfacial fractures, where all the facial bones including frontal, nasal bone, nasoorbitoethmoidal bones, and zygomatic bones, maxillary bones, mandibular, all the bones fracture, then it is called as panfacial fractures. So again, another 3D view. Here you can see comminuted. So as I told you, whenever and wherever we suspect multiple fractures, where we suspect the comminuted fractures, uh, we can see those. We always order for the CT with 3D reconstruction. So remember this, the name of this X-ray, that this is called CT scan with 3D reconstruction. So here you can see the ramal fracture. Here the arrow shows. So what are the red flags for the general practitioners? If the patient have airway compromise sign, like patient is asking, gasping for the air, he's gasping for the air hunger, which most of the times happens in maxillary fractures, or the patient asks for the diplopia. Diplopia means double vision. So if a patient comes to you with the suspected injury to the zygomatic bone, you can ask him if he can see one object at a time, one, or is it a two. So you can place your finger and he can tell you that either it is one finger or two, and then we have some specific tests. But you don't need to go for that test, but you can just ask the patient if he can see a single vision or double vision. Then it is very easy for my colleagues who are doing general practice in the dentistry, that malocclusion. If a patient closes his mouth and the occlusion is deranged after the trauma, so again this is a sign for the fracture. And also you can ask for the numbness to the infraorbital region. So again, very important sign, just note this with you, that whenever there will be fracture to the zygomatic bone, there will be numbness to the lateral wall of the nose, to the cheek area, to the upper half of the upper lip, and the four incisors on the same side. So this is again another very important sign. You ask the patient that if he has a numbness in that area or not, so that you can diagnose that he might have fracture over there. And of course, severe swelling and severe pain in the fracture area is the suspicion, and you can check the tenderness over the fracture area. You can gently feel with your index finger always. You can palpate over there. You can see the step deformity over there. So, coming to the role of the general practitioner. So, take the basic radiographs if available. Recognize those red flags, as I already told you, and stabilize the patient. Like if the mandibular fracture is there, and you can see, you cannot refer the patient immediately to the hospital. You can just have a simple wiring between those fracture segments, and basic stabilization you can do, and this can be blessing to the patient. And then of course refer the patient promptly to the oral and maxillofacial surgeon. So coming to the summary, early recognition is the better outcomes. Many patient comes to us that fracture is not diagnosed by their general practitioners, and the patient used to eat normally, and this causes the displacement of the fracture further, and this can cause more difficulty for the reduction to the fracture. And you can have OPG X-ray, you can have PA view, you can have Waters view. These are essential for the general practitioners. And then, as I told you, the gold standard is CT scan if available, and always correlate the clinical plus radiographic findings to diagnose any fracture. So, thank you very much. With this, I will would like to conclude this today's talk. To the host, I would like to thank you very much for giving me opportunity to present this very important topic to my colleagues, to the general practitioners. So I think you are most welcome. Here is my email address, my WhatsApp number. You can ask questions anytime. Thank you very much.
Thank you so much, sir, for such an insightful lecture. Praise and comment. It was a very insightful and amazing session. Learned a lot. In closing, we would like to express our sincere appreciation for an enlightening session on radiographic clues to maxillofacial fractures in general practice by Dr. Ehsan Ul Haq, a distinguished oral and maxillofacial surgeon. Thank you, Dr. Ehsan, for sharing your valuable insights. We also thankful all the participants for joining and contributing to this webinar. Experience Dentistry hopes the knowledge and gained today will be beneficial in your practice. Thank you so much. Thank you, sir. It was a great learning from you.